Thank you very much, and thank you to Dr. Palaswamy and our good friend Basu for inviting us back. I was struck by this morning's talks that I remember as a research fellow a few years ago now, 1995, in Nottingham, with a guy called Chris Hawkey. And that famous gastroenterology front cover, I should explain for the young people, no internet, no mobile phones. We read paper journals made of paper, like a proper magazine. And the front cover of gastroenterology showed a Crohn's perianum area and then a healed picture. I don't know if the older guys may remember that, but this morning it struck me how far we've come from that day in 95, infliximab for perianal Crohn's, to those talks this morning about all these molecules I'd never heard of. So, yeah, fantastic. So I've been asked to talk by Basu about acute severe colitis do's and don'ts, and I would say that these are things that I haven't done and things I have done in my career in gastroenterology, and I've got it wrong more than once. I've had to put this slide up because some of us are very proud of being only the second WEO Centre of Excellence in endoscopy after St Mark's in the UK, so I was asked to put that up. So acute severe colitis, I think we forget that acute severe colitis is and was a very serious problem. And it still affects quite a lot of patients. So maybe 1 in 5 patients get acute severe ulcerative colitis. And we've managed to get mortality rates down, but we still have persistently high colectomy rates. Around a third of patients end up having a colectomy with acute severe colitis. And then more recently, we've seen biologicals used earlier and with great effect to prevent colectomy as well as saving lives. So we don't believe in reinventing the wheel. The more mature members may recognise these two guys, Sidney Truelove and Lawrence Witts, who were both in Oxford together in the 50s, and they produced the first ever study proving that steroids save lives in acute severe UC. And just the line at the bottom there, it says that the mortality rate for acute severe UC before that study was published was around 25–30%. So 1/3 of patients who came with acute severe UC died. Is that better? 1/3 died. Okay. Now, that one study published in the BMJ in 55 reduced that mortality rate from around 1/3 to less than 10%. And I think that Vinet said in the first talk this morning, second talk this morning, time hazes me, that the impact of studies was greater in the 50s and 60s than it is now. Well, that was one study that changed our practice and changed lives. Truelove and Witts, of course, gave us the Truelove and Witts criteria, and you'll all know this, these criteria, I'm sure, based on number of motions per day with visible blood and at least one of a high temperature, tachycardia, anemia, or raised ESR. And we still use Truelove and Witts today, mostly. So the first do use Truelove and Witts to diagnose acute severe UC. There are other scoring systems around, and I'm sure if you're keen and dedicated and lots of time, you can use the more complex ones. But the ones that we still use in the UK mainly are Truelove and Witts. So that's the first do. Use Truelove and Witts or another criteria to actually label people as having acute severe ulcerative colitis. The second do is to start IV high-dose steroids promptly together with thromboprophylaxis. And in fact, although the first study was published in 55 by Truelove and Witts, the Oxford regimen, as it was then called, only came out really in the mid-early 70s, and that is high-dose IV steroids for 5 to 7 days with an early colectomy for non-responders, and that brought the mortality rate down from those 1/3 of patients to vanishingly small, less than 2% of patients were dying with acute severe UC. We shouldn't underestimate, however, that acute severe UC is a life-threatening complication of ulcerative colitis that kills patients. The next do is closely monitor, reassess frequently, daily CRP, hemoglobin, albumin, plain films, and involve the surgeon's stoma care early. So what I don't want to do is spring a surgeon and a stoma nurse on a patient who's been ill for 7 days, 9 days, is going downhill rapidly, feeling very terrible. We bring this big man in with his big metal knife and we say, right, this man's going to take your bowel out. I think it's really, really good practice to involve them on day 1 or day 2. And we've got some fantastic surgeons we work with. I remember one guy, particularly Paul Skinner, colleague of ours. he'll come in and say, I'm just touching base with you. Nice to meet you. You won't see me again, but if you do meet me, I'll be back in about a week's time. And just to preempt that whole discussion about surgery and stoma early on, don't leave it till they're really, needing it, they're acutely unwell. Do it very early. So that's the third do. The fourth do is to do an early, unprepared flexi-siggy. We'd prefer that within 24 hours, maximum 48 hours. You're not doing that really to prove or disprove the diagnosis. These patients have UC, but you're doing it to help you exclude complications of the UC, like infection with C. diff or CMV. And also you can get an endoscopic idea of how bad things are. So we never like deep, serpiginous, snake-like ulcers in acute severe UC. They're a bad sign. So it gives you a view of the mucosa, but it gives you a chance to exclude concomitant infection. Really important to do that. There's more Oxford links now, I'm afraid. So just a bit about scoring systems, predicting non-response. So Simon Travis is the main author of the Travis score, but Derek Jewell was his mentor and professor at Oxford. And in fact, whenever I see Derek's picture, it always slightly unnerves me, because years of giving presentation to the BSG and Derek Jewell in the audience standing up to ask a question is absolutely horrifying. So I'm slightly nervous just here looking at him now. The really interesting thing about Simon Travis' study and the whole Travis criteria, that was a retrospective case series of 48 patients. So it wasn't an RCT, it wasn't a meta-analysis, it was 48 patients that Oxford looked back on and said, if you have acute severe UC, what identifies if you do badly? And that's what Travis criteria are based on. So the Travis criteria, as you know, are on day 3, has the patient still having 8 stools a day, is a CRP more than 45? If they have that on day 3, they've got a high chance of colectomy. There are other scores, but I've got to say, again, I spoke to my younger colleagues before I came out here from the UK, because I don't do IBD anymore. But I spoke to them, I said, are you still using Travis? They said, oh yeah, still using Travis. What about the Scottish ones or Lindgren? And they're too complicated for the juniors to understand. We just use Travis and it's easy. So do use Travis. Here's the first don't. Don't ignore the data. So if the CRP is more than 45 or there's more than 8 stools a day on day 3 of high-dose IV steroids, there's a high chance of non-response. You need to do something. I think it's always tempting to say they're looking better, they're feeling a bit better, they say they're feeling better. Ignore how they feel and how they look. Go on what the data's saying. Have they still got torrential diarrhea? Is the CRP still going up or hasn't come down? You need to change something. What do you do on day 3? Well, I think there are a number of options, really. So I think infliximab is definitely flavour of the month in the UK. Cyclosporin had its day, but cyclosporin seems to have faded from the scene, really, in terms of acute severe UC. We're using infliximab now on day 3. Obviously, in this country particularly, you need TB screening. We do TB screening in the UK as well. There's questions around infliximab dosing. What's the regime? Do you go for a high dose early on and then taper down quickly? What are long-term safety data like? And of course, there are new molecules around that I can't pronounce, but the new molecules may take over infliximab, but right now, it is day 3 non-responders infliximab. And I've got another don't for you. Despite infliximab and all these fantastic things, the final don't is don't delay colectomy. So I worked for someone once who said to me, they're better off going home without a colon than going home in a coffin, which is dramatic stuff, but it's absolutely true. The mortality rate for colectomy, if the acute severe UC is non-perforated, is vanishingly small. If they perforate, that mortality rate goes up to 30%. So it's really important not to delay colectomy. If they need a colectomy, have the colectomy done. So to summarise, acute severe UC do's and don'ts. Do diagnose early, use true love and wits. Do start high-dose IV steroids and thromboprophylaxis urgently. Do monitor closely with the early involvement of surgeons, stomotherapists, etc. Do an early, unprepped flexi-siggy, exclude CMV and C. diff. 2 don'ts. Don't ignore the data. So the patient, if the scoring system says they're going the wrong way, they're going the wrong way. It doesn't matter how well they feel, how well they look, they're going the wrong way. And then finally, don't delay a colectomy. If they're not responding on day 3, infliximab. If not responding on day 7, colectomy. And I think I'm the first person to be well within 15 minutes. Thank you.